Hi guys, good morning. We have already finished half of the general surgery in my last video, and for now we will complete the rest of the part, and it is very small also. So let's start. The topic is the ulcer. So usually they will give you also the clinical history, and we have to diagnose. So if it is venous, varicose, or healing ulcer, the history will be of varicose vein. Okay. Remember, it is healing ulcer. It will heal spontaneously, slowly, gradually. If they will give you history of a pain when walking, also when there is pain when the patient is resting, or there is absent peripheral pulses, it is most commonly arterial ulcer, and it is a non-healing ulcer. The patient will complain that the ulcer is not healing and it is progressing beyond months, and usually it is on the dorsal aspect of the foot. Then comes the basal cell carcinoma. It is also called rodent carcinoma or rodent ulcer. Usually they give a picture of an ulcer on a face, and you will see that it has everted margin, and in the middle there is nothing. And usually they will give a picture of face, and also they will ask you difference between what is the difference of basal cell carcinoma and squamous cell carcinoma. Squamous cell carcinoma, they will give you picture of tongue, and also it has some of irregular margin, then nothing, then irregular margin. This is also called as cauliflower like ulcer. Okay. Also, you should know the difference between basal cell carcinoma, squamous cell carcinoma, also as tinea, because usually they all look similar, so you should know, and they are definitely testing this nowadays in the exam. For example, in last exam in January 2025, squamous cell carcinoma was asked, also basal cell carcinoma was asked, and in the option they will give you all the similar kind of option like BCC, SCC, tinea, and other type of ulcer. So you should know the difference between all the ulcers. This is a very high yield topic, and every time one or two question is asked. Then if there is just a ulcer on the plantar aspect of the foot, and they will also give you a history of like a patient is bedridden, then it is kind of a pressure sore, which is also known as trophic ulcer. Then if a patient has a history of diabetes, and also the ulcer is painless, the patient does not know when it started and when did the ulcer progress, it is most commonly a diabetic ulcer. It is usually found in the great toe and heel. Then if the patient has a history of ulcer, on a burned site, the patient will have a burned site, and after that the ulcer form, it is a Marjolin's ulcer. So this is done. The next topic is triage. So suppose in an emergency a patient suppose a patient came to the ER, and how will you triage, like what should be the numbering you should give to a patient to get treatment. So red means it is emergency and you have to treat the patient right away. Yellow means the patient is stable, there could be history of fracture which is non-lethal, we can admit the patient, we can monitor the patient, and we have to give some kind of treatment within 6 hours, then it is a yellow. Green means it is a minor, for example scratches, bruises, abrasion, patient is stable, then it is green. Black means the patient is dead. Then one of the most important topic is ATLS. Usually one or two question is asked either in adult ATLS or pediatric ATLS. What you have to do is A, B, C, D, and also sometimes E also. A is airway, breathing, circulation, disability. E is exposure. But remember, if a patient is admitted, patient is intubated, patient is under treatment or monitoring, then and suddenly patient collapses, the heartbeat is gone, then you won't do ABCD, you have to do CAB. For example, you have to start with circulation, which is the chest compression. So remember that. So how we have to manage is, we have to first give airway. We have to take airway. In airway, first of all, if a patient comes in an emergency, we have to do a cervical spine stabilization. This will be the first step. Then we have to see if airway is patent or not. We just need to ask the patient. If patient is oriented, we have to say patient to speak. If patient is able to speak, which means airway is stable and patent. If he is not able to speak, then the airway is not stable and we have to do further process. Then the third is we have to see the patient. If the GCS is less than 8 or patient is not speaking, we have to directly intubate the patient. But before intubation, if the patient has any relative with him, we have to rule out alcohol, because sometimes when person drink a lot of alcohol, he tends to get unconscious, and without any pathology we will falsely intubate the patient. So first of all, rule out this patient. Actually, in my internship I had a case like this. One of my resident, he intubated the patient, and after 6 hours the patient came back to consciousness, and he was like, what have you done to me? And he kind of sued the resident because he falsely intubated the patient. Suppose if you try to intubate the patient and it fails, so what will you do? So if in an emergency setting, you will do needle cricothyroidectomy. And if they will ask what will be the definitive management, then it will be tracheostomy. All right. And what will be the most common complication of tracheostomy is subglottic stenosis. Then comes the breathing. C is for breathing, is just you have to see the chest rise and chest down. Then C is the circulation. What we have to do, we have to resuscitate the patient. So usually in emergency, we will resuscitate with the IV cannula, which is green in color, and we will give fluid. Fluid could be NS, RL, anything, depends on the emergency. Suppose if the patient has a lot of edema on the periphery and we are not able to put the IV, then what will be the emergency management? We can give peripheral fluid also from great Cephas vein, or we can also do intraosseous. What will be the definitive? Definitive will be we can use internal jugular vein. Then comes the disability. Disability means we have to see GCS, and GCS is also one of the very most high yield important, I'll say, a topic. Every time at least 2 question is asked. Like in January 2025, 2 question were asked just in EVM, and it is very easy. If you are able to do it, you will definitely get 2 marks. So how to do GCS is you have to do EVM. EVM is 4, 5, 6. EVM 4, 5, 6. For 4 is spontaneous, 3 is speech, 2 is pain, and 1 there is no stimulus. Then verbal is 5 is orientate, 4 is confused, 3 is inappropriate word. What do you mean by inappropriate word? Suppose if you ask the patient what is your name and he will say Taj Mahal, this is inappropriate. That will be confused. What will be the inappropriate is the patient is not able to tell you anything. What is incomprehensible? Incomprehensible means the patient is just able to mumble like that. It will be 2. What is number 1? The patient is not able to speak. M is the motor response. Motor response, obey is 6, localize is 5, withdrawal 4. Now this here they test very much. What do you mean by abnormal flexion? Abnormal flexion is also called a decorticate. If you will try to stimulus and motor response, the patient will move his hand towards his core. This is how you can remember decorticate. Alright, this is 3. What do you mean by abnormal extension? It is called decerebrate. In that, on stimulus, the patient hand will be out. It will be away. It will be extended. So it is decerebrate. And 1 is no response. What is the maximum GCS score? It is 15. What is the minimum GCS score? Which is 3. If the patient is dead or in coma, it is 3. Other than GCS, now they are also testing what is GOS, which is Glasgow Outcome Score. It has been asked in NEETPG also, INICT also. So very high probability they will ask in FMGE also. So it is, the score is, if the patient is dead, the score is 1. If the patient is coma or in vegetative state, it is called 2. Patient has severe disability, 3. Moderate disability, 4. And if the patient can fully recover, it is 5. So this is also done. Now the next topic is abdominal trauma. So in that, usually they ask what is the most common. So overall most common in abdominal trauma will be in spleen. Blunt will be in also spleen. Penetrate, it will be in liver. Gunshot, small intestine. Seat belt injury is mesentery. Remember this. If the patient is wearing seat belt and the patient had accident, the most probably trauma will be in the mesentery. If the patient is not wearing a seat belt and if there is an accident, which is also called as deceleration, then the most common trauma will be at the DJ flexure. Did you know jejunal flexure, which is called DJ flexure? Now suppose the patient came, what will you do? So the most fast thing you can do is this fast. This will test the epigastrium, right hypochondrium, left hypochondrium, and pelvis. And also we can do E-fast. E-fast is called extended fast, where we can also analyze the thorax as well. All right. Then what is the lethal triad of trauma? It is coagulopathy, hypothermia, and acidosis. If there is anything in the patient, it is higher chances the patient will not be able to survive. And even in your internship ER duties, you must have known the patient who have acidosis or coagulopathy or active bleeding, or the patient is very cold. The patient usually is not able to survive. Now comes the thorax. Thorax, usually they ask what is the definition of flail chest. So the definition is more than or equal to 2 fractures in more than or equal to 2 consecutive ribs. It is called flail chest, and also there will be paradoxical chest movement. Okay. Now the another very important is difference between pneumothorax and cardiac tamponade. You know what is the difference, but when the question is asked, usually you tend to confuse because of some of the following thing. Because in both of pneumothorax, cardiac tamponade, respiration will be high, cardiac output will be low, JVP will be high. Then what is the difference is if you are doing to do physical examination, because both are clinical diagnosis. On percussion, pneumothorax has hyporesonant sound, and on there will be no breathing sound. However, in percussion, in cardiac tamponade, there will be hyporesonant sound and breathing sound will be present. And how is the heartbeat? It is muffled heart sound. What is the management of pneumothorax? So in adult, we have to put ICT in the 5th intercostal space, and you have to put on the upper border of the lower rib. For example, you have to put in the 5th intercostal space, which is between 4th and 5th. So you have to put the ICD in the 5th intercostal upper border. And if it is a child, then we have to put into the 2nd intercostal space midline. How you are going to put the dressing on the ICT tube? You have to do a 3-way dressing. All right. And you can also see that we have put the ICT into a water bag. So when the patient take inspiration, expiration, the water column will move up and down, and this is very normal, and it shows that the ICT which you have put is patent. Okay. What will be the management of cardiac tamponade? It is cardiocentesis. Now comes the skull. Usually one question is asked from skull. So if there is fracture of anterior skull and there is a cribriform plate fracture, then there will be CSF rhinorrhea. How will you test there is CSF? You can use handkerchief test, halo test, or target sign. And if they will ask how will you biochemically confirm that this is CSF, it will be beta 2 transferrin. Usually they will give you a history of that after a trauma patient has a clear fluid coming out from the nose. So usually this is a CSF, and this question was asked in FMGE 2025 January. There will be also black eyes or raccoon sign in anterior skull fractures. What will be present in middle skull fracture? Usually it is formed on the petron part of the temporal bone, which is on the mastoid side. There will be Battle sign. Diffuse axonal injury. If there is an MRI which shows punctate hemorrhage, it is diffuse axonal injury and it has the worst prognosis. Then comes subarachnoid hemorrhage. Okay. Now the next is subarachnoid hemorrhage. So subarachnoid hemorrhage occurs between arachnoid matter and pia mater. It is it is very rapid progression. The patient will start to have a very bad headache, which is also called worst headache of his life or thunderclap headache, and it will go towards his neck also. And if you will do a spinal tap, there will be bloody or yellowy spinal tap, and the most common is trauma, but usually if it is idiopathic, then it could be the rupture of Barry aneurysm. Then comes the extradural or epidural hemorrhage. Extradural is the middle meningeal artery. Remember, extradural is arterial blood. The patient will have lucid interval. Patient will have consciousness, unconsciousness, like that. The site is terion. Usually the patient has not usually, like every time the patient has biconvex bleeding, or which is also called as lentiform bleeding, and it does not cross suture line. Subdural has the bleeding from bridging veins. This is venous in nature, and the shape is crescent or banana on CT. This can be also seen in shaken baby syndrome. Now in in extradural, subdural, when will you perform surgery? When the bleeding inside is more than 30 cc, or there is more than 5 mm of midline shift. Usually the surgeon will do prophylactic surgery because they know the prognosis is not good, and they will do burr hole. All right. Now the next topic is burns. So in this you have to remember the Wallace rule, right? The Wallace rule, because in this one question was asked. Wallace rule is how you are going to define in adult and children the percentage of the surface area which is burned. So you should know about Wallace rule. Read in your main notes. In adult, how will you give fluid? You will go 2 multiplied by body weight into total body surface. Children, 3 multiplied by body weight into total body surface. In electrical injury, 4 multiplied by body weight into total body surface area. Now this is the fluid you have to give. What is the fluid of choice in adult? It is RL, which is crystalloid. What is the fluid of choice in child? It is RL plus 5% dextrose. What is contraindicated? Contraindicated is dextrose. You should not give like 10%, 20%, 25% dextrose, because it is hyperosmolar. It will make the patient more dehydration. Usually the dehydration in patient is due to albumin. Because of the burn, the albumin will lose out from the extracellular and to the outside, and it will also take water from with it, because it is also hyperosmolar. How will you give fluid? So suppose you have calculated the total amount of fluid, then half of the fluid you have to give in the first 8 hours, and the rest half you have to give in 16 hours. So you will get the total fluid you have to give in 24 hours. Then what is the difference in electrical burn? Is that electrical burn will cause rhabdomyolysis, and due to which the creatinine will increase and GFR will decrease, and it can also cause acute tubular necrosis. This question was also asked in FMGE 2025. Okay, now comes the chemical burn. In chemical burn, if there is acid burn, we can see coagulation necrosis, and if it is alkali burn, we can see liquefactive necrosis. From both of them, which is the most toxic and which is very had bad prognosis is the alkali. You should not give, like, if there is acid burn, you give base, and if there is alkali, you can give anything else. Not like that. You just have to follow the protocol, where is you have to wash it first with the water, and you have to give the appropriate treatment. Now comes the very important topic, which is shock. So first we will read about hypovolemic shock. Hypovolemic shock is divided into class 1, 2, 3, 4 based on the percentage of blood lost, which is 0 to 15%, which is 500 cc. 2 is 15 to 30%, 1 liter. 3 is 30 to 40%, 1.5 liter. And 4th is more than 40%, which is more than 2 liters. Remember, one question they asked is, this is normal. Class 1 is normal. It is like having a mild blood loss, or you have given blood donation, then it comes under class 1. This is not an emergency, and it is not very significant. Second is called compensated phase. Class 2 is called compensated phase. Usually there will be change into the physiological state. For example, urine output first starts to decrease in this compensated phase. This is also asked question in NEETPG, so most probably they can ask in FMGE also. Then third, then comes fourth. This is emergency, and here you have to manage. Then how will you manage? In class 1, you just need to give oral fluid. In class 2, you can give IV fluid. Class 3, you have to give rigorous IV fluids. And monitor, because it can go to class 4, which is very, very bad, and you have to give massive blood transfusion for the management of class 4 hypovolemic shock. Okay, now this is done. Now comes what is the difference between cardiogenic shock, neurogenic shock, septic shock. Okay, so cardiogenic shock means it is something related to heart. Then there could be MI, there could be some kind of tamponade. What is neurogenic shock? Neurogenic shock is is due to road traffic accident, where there will be transaction of spinal cord. Spinal cord is not working. So spinal cord is not working, there will be no signals to all part of the body. So this is neurogenic shock. Then comes the septic shock. Suppose a patient has some kind of disease and the patient gets sepsis or in a very high infection, then the patient can get septic shock. Now the question they ask is, what will be the difference in the cardiac output, blood pressure, peripheral vascular resistance, and JVP? So you should know about it. Neurogenic is very easy because nothing is working, so everything will decrease. Cardiac output, BP, peripheral vascular resistance, JVP, everything will decrease. So this is done. Nothing to worry about it. Now in cardiogenic shock, heart is not working, so there will be no cardiac output, like very less cardiac output. BP will be less. If there is no output, what will be the resistance outside the body? It will be high. And if heart is not working, the blood will be pooling in other parts of the body. That is the reason JVP will be high. The blood is pooled in the periphery of the body, so if you touch the patient, how will it will be cold. Now comes the septic. Septic is divided into two, warm and cold. Septic warm is same as in warm there is a lot of infection, so cardiac output will increase, BP will increase, the resistance will decrease, and JVP is normal. So there will be no changes in JVP. But in cold, which is the late phase of septic shock, what will happen is there will be increase in toxin. Due to which it will be same as cardiogenic shock. The cardiac output will decrease, BP will decrease, peripheral vascular resistance will increase, and JVP will increase. So cardiogenic shock and septic cold shock are same. You should know that, and they can ask you the question like this. So here we have completed our general surgery. For this note, you can join my Telegram group, which is Dr. Prince. All my notes and all my other video notes are in this group. You should definitely join this group. I give questions and all my notes and teaching how to read, what to read, because it is better you pass your exam in your first trial. You don't know what will government do in the upcoming years, what rules they are going to change regarding internship or passing the exam, or if there is next exam. In next exam, you first have to pass the exam, then you have to do 1 year internship, then you will also have to do the exam for your internship. So it will be very, very long process, and we have already studying for like 5 to 6 years in a foreign country, and after that you have to wait, or you have to attempt 2-3 times. You are wasting 1.5 years, 2 years, then it's not good. So it's better you read all this. I have made this note just to make you pass your exam. There is nothing for me in this, because I've seen my very good friends who were studying like 10 to 12 hours, yet they failed because they were not able to revise it properly, and they did not know what to study and what is important, what is not important. So this is like very small. It is like small pages, 10 pages. So you can finish this in 10 minutes. So why are you not studying from this? And also subscribe to my channel. I'm going to put more videos like this. So my next topic I'm going to teach is breast, and see, the breast is just 4 pages, small 4 pages, and from these 2 pages 3 questions were asked in Jan 2025, and I was able to mark it. I just studied for 1.5 months and still I was able to pass because my strategy was good. So don't take this very lightly, and if I am putting so much effort for you, you should also put effort for yourself also. So this is it. Thank you. Subscribe to the channel and join my Telegram group. I hope it will help you, and it will definitely help you. Thank you.